Hello and welcome to NCGPA Live, informative conversations about general practice in Nottingham City. I'm Dr. Andy Foster and I'm joined today by Dr. Jane Turrill. There we
Hello.
go. Hello, Jane. And Jane is clinical lead at NCGPA for SMD and is also a retired GP. Today we're going to be having a deeper dive into the possible ways that Nottingham could lead the way in severe multiple disadvantage within primary care. If you didn't catch our previous episode with Jane, you can find that in the show notes or look it up on the NCGPA website. This is part two of a two-part conversation. In the first part, we defined SMD, severe multiple disadvantage, and talked about some of the work already underway in Nottingham to support patients with SMD. In this second conversation, we will be looking into the future plans for SMD in Nottingham City, and how this links into national and local strategy and documents that have been published recently as we have this conversation in November 2022. Just a reminder about NCGPA. NCGPA, Nottingham City General Practice Alliance, is a federation with a membership of over 40 GP practices in Nottingham City. And we hope that these NCGPA live conversations will be of interest to local practices and people working in or who have an interest in primary care, and perhaps people working more widely on the topics of primary care networks, GP federations, primary care and the NHS more generally. Hopefully you will all find this interesting. We're aiming to have a fairly free-flowing podcast-style conversation on this topic, and we hope that you will be entertained as well as informed. So as I always say, carry on doing your ironing, continue to drive your car, keep your eyes on the road as you listen to our conversation. So just to complete my introduction, I'm Dr. Andy Foster. I'm an NCGPA board member. That's the organisation producing this podcast. I'm the Balwell and Top Valley Primary Care Network Inequalities Lead, and I'm the Deputy Inequalities Lead for Nottingham City Place-Based Partnership. And I am a GP who works within Nottingham City. And Jane, do you want to introduce yourself?
Thank you. I'm a retired GP from clinical practice. I worked in a wide variety of practices over my career and also had a period working in occupational health. I worked both as a partner and as a salaried GP. And over the latter part of my career, became more and more involved in work with those suffering health inequalities and severe multiple disadvantage.
Excellent. So in the first episode, I think we got as far as talking about how practices can support patients with severe multiple disadvantage and how the system is currently helping them, looking at things like changing futures and the local enhanced service for SMD, for example. And today, I guess we're focusing on looking a little bit more forwards, really. So my first question is, we talked about some practices supporting patients. How can we support practices better to look after patients suffering with SMD?
Yes, I think it's a very opportune moment to be looking at this in the sort of post-COVID crisis world, and also post the in Nottingham City, particularly there are several practices who are what one might call the usual suspects, who have a lot of patients who fall into this category. But increasingly, we've been looking at how to support practices more generally across the city and the county. I think it's really important to actually look at the needs of the staff in the practices and to support them to support patients. And part of the Changing Futures programme, which we touched on in the last podcast, is around system change and putting workers into various parts of the system, primary care being one of them, to actually work within the system to look at what training and support is necessary. Now, also my role with NCGPA in looking at SMD, both in terms of the response of the city as a whole, but also in terms of how NCGPA can enhance the work of practices and support practices in this area. And this led directly to my becoming a senior fellow on the Phoenix programme, which again we did mention before, which essentially means that I have a small amount of funding for a short project to look at how we can create if you like, a centre of excellence in SMD in primary care in the city. The more I look at this, the more it aligns with health inequalities generally, because I think when you look at multiple disadvantage in the city in primary care, not only do we need to be looking at how we best support those with very, very high levels of need, we actually need to be looking at early intervention and prevention, which really is about addressing health inequalities, particularly around sort of access and the flexibility and non-judgmental nature of the type of care that people need to equalise, if you like, access across different communities within the city. Now that centre of excellence can take on many forms. Working with the embedded primary care worker, we've already identified, I've sort of identified that there are various elements in that, mainly 4 elements. An online presence, a research element, workforce development and support, and most importantly, listening to the voice of lived experience, and in a meaningful way, and having ongoing lived experience input into research and into training and to the whole development of the way in which primary care works. Now,
sorry, Jane, I've interrupted you. I was just curious to pick apart the diagram on the screen. So you can do this, or you can go back to what you were about to say. But I was just wondering what each of these could look like and what the impact could be, you know, of having an online presence, for example, or you know what the research component of this might look like and what that might mean for practices. So I was just wondering if maybe if you wanted to, you know, take say online presence and just kind of run with that a little bit.
Yeah, sure. Bizarrely, that's exactly what I was going to do. The online presence element is actually well underway in terms of its development. The Changing Futures Embedded Worker has taken this on board and has developed a portal which is found on our TeamNet system within the city, which has access to a directory of services. It has access to information on training. It has access to information on local updates. For instance, the Place-Based Partnership, SMD Partnership, produced a document identifying the particular organisations which were targeting work on financial vulnerability with the cost of living crisis, and that's published on there. So it's responsive, it's kept up to date, and it's there for everybody to access. And we do want to expand that with links to more training and perhaps an online discussion forum, those sort of things where people can post questions. But really, it's about keeping that. It's part of the communication network, if you like, which I think is incredibly important. Having said, we recognise the online presences are very important. What we have found is that one of the better way, it's sometimes the training is much better delivered face to face, and I know that's been found in other areas of the county as well. And so Martin has been working in conjunction with that to work around the practices to begin delivering training.
Yeah, that's really good. I know I've looked at the SMD portal on TeamNet, our local intranet. It is really, really good. I have looked at the cost of living crisis information there, which I think is really, really helpful. So I hope people can go away and look at that if they're within the Nottingham area. And there's real value, isn't there, of having a place where people know that they can find information about a topic and they know that it's kept up to date. So I think that's really, really important.
Yes, and I think as well, Martin's been very involved in the primary care network roles, particularly the social prescribers, and has done a lot of work with them. And obviously this is a tool which is available for them as well.
Absolutely. And wondering which area you want to talk about next. In a way, we talked about training, so maybe that relates to workforce development, and that's a good direction to go in next. And what might that mean for a Centre of Excellence in SMD?
Yes, I think we touched in the last podcast about pie and tick training and the SMD local enhanced service that was been developed in the city. I think training around the requirements within practice to look at how we best provide a flexible and non-judgmental service with pie and tick it's available in several forms. So there are online resources and training programs that are there through the practice development unit, which is available on a link through the online portal. However, we haven't sort of realised, and indeed we were talking about this just before this podcast, around the natural way that conversational, experiential, and sort of looking at the voice of lived experience in terms of understanding and development of people's appreciation of the issues around health inequalities means that a lot of work that we want to do in the future is on face-to-face delivery of training and sort of workshops and ways in which we can perhaps be more innovative with the sort of online resources and podcasts such as this, interviews and that kind of thing to help people in a more slightly less formal way than, say, some of the mandatory training presents itself to work around this kind of area. And I think one of the things to emphasize is that all of this training is or the way in which we work in supporting people with health inequalities is not just about getting a better service for patients or those experiencing severe multiple disadvantage. It's actually about supporting the health and well-being of staff, because it makes everybody's life a lot easier if their work environment is pleasant and if their encounters with patients are without conflict. And also that in dealing with situations that can be very difficult and traumatizing to staff, that they feel, or rather hearing things that can be very traumatizing, that they feel supported and that there are systems in place for them to seek help and support in particular circumstances that they may encounter.
Yeah, I think you're right. Again, I'm just drawing back to the conversation we had before the cameras started rolling about this. But it almost felt like there's another angle that can be exploited, if that's the right word, to get practices more engaged with the SMD work. And that's actually, as you say, sort of stressing that actually training your staff in this area and being involved in the learning around this area can actually reduce conflict, reduce friction points within your organization. Actually it's challenging and it's draining often to deal with people experiencing severe multiple disadvantage. There's often very difficult conversations that happen at the desk or in consulting rooms. And actually I can see how taking a psychologically informed environment approach and a trauma-informed care approach can really help both diffuse those situations when they happen, anticipate them, anticipate that they will occur in how you design systems and design them in such a way to avoid them, and that actually that can improve the experience for staff, help with staff retention, and also help reduce complaints and other things which take up a lot of time at practices. So I think that's really an angle to stress. Actually, it's not all about asking practices to do something else to help a patient group at a time when we're feeling stressed. Actually, a lot of this can help practices be more effective, more efficient, and happier places as well, with happier workers. So I thought that was a really interesting conversation. It's a shame that the cameras weren't rolling, but it was good.
Yes, indeed. And I think the benefits of working in that way can be felt by other patients too. And as we were saying, there's almost a continuum of patients. Rather than putting people in categories, there will be times in everybody's life when they may sort of find themselves in a particularly stressed and difficult situation, and having receptionists or medical professionals who understand and can respond in a trauma-informed way is actually really beneficial for everybody, and that can minimize it can help to decrease the trauma that person experiences when they encounter services, and that can then enhance their engagement with services in the future, because they're not coming in expecting to encounter difficulties and rejection and the sort of things that we're all aware that can happen, not just in health services but across all statutory services.
No, absolutely. Sometimes people arrive almost on the defensive, and that just sets up a bad interaction. So anything that can reduce that is really valuable. This sort of relates really to understanding the lived experience of patients experiencing SMD. So, and that's one of the other 4 areas contributing to the concept of this centre of excellence. So
yeah,
why is that there, Jane?
I think any work that we do in looking at service development needs to start with the experience of the service user. This is embedded right at the heart of all the Changing Futures work, and I think increasingly we'll see that it will become a prerequisite for service development in many areas. I think we learn a huge amount from listening to people who have experience of both disadvantages but also of using the system. I mean, we're all aware of patient participation groups, but I never felt as a GP that overall that they really got to the heart of this kind of service development issue. And indeed, that wasn't really what they were. They were a relatively light touch in terms of in diving into the patient experience. And I think as well, what we've already got some way in along this route. There are various lived experience groups within Nottingham. The oldest lived experience group, which is allied to the substance misuse and mental health services, is already based, physically based now at our headquarters within the Parliament Street practice, which means that we have, if you like, an instant connection and a relationship, so that when we need support and help in what we're doing, they're there for us to call on. And indeed, a lot of the members of that group were actually already familiar with Platform One and its work, and in fact were patients. So there's a natural connection there and linkage, and that's working very closely that's facilitated by the City Council. So again, this is partnership working within the city. I think it's as again we touched on before, that the early strict definitions of severe multiple disadvantage tend to not identify the needs of underrepresented communities, of the BAME communities, and also women specifically. And I think I'm making inroads into getting into a position where we can hear their voice. And I'm working very closely with Response to Complexity group in Nottingham, which is the broader umbrella group for all those who work in women's services. Also within the homeless services, we're working with them. Within probation, we've already got links with them to look at how we can best improve prison, the experience of people on prison release. And again, we're working very closely. There's a large work stream within the place-based partnership SMD group looking at BAME communities and looking at how we can work better in those areas, and how disadvantage and health inequalities present differently in different parts of the city, but the principles of how we can work together and the way in which we work actually does actually remain the same underneath all of that. And it's just supporting practices, whatever community they serve, to be able to do that. And I think ultimately the name SMD in terms of primary care probably should have "and health inequalities" added to it, because they're absolutely two sides of the same coin, and or rather different bits of the pyramid, if you like, and looking at how we can get in place early intervention and prevention so that people are supported not before they need very high-end services, but also when they are when their situations improve and perhaps people are in stable accommodation or whatever, that they're not just lost to the system at that point because they're no longer needing high-end services. They actually still need ongoing support within primary care to prevent relapse.
Absolutely. Another area is research. So research on here as well. How do you anticipate that being part of this Centre for Excellence?
Right. NCGPA itself has is in the process of developing a very strong research ethic, working very. They have a research lead, Ed Turrill, who works at the university, and we're developing partnerships within all the educational establishments and training establishments across the city and the county, and the health research organisations, in order really to improve the quality of research that is coming out of general practice, so that it includes those from underrepresented communities, and that it becomes an aspiration for practices to be involved in research, and also in terms of for newly qualified GPs, that it becomes an option for them as a natural process to explore research, whether that's in a particular clinical service, whether it's in service development, or whether it's in any particular field that they're interested in. Within the field of health inequalities and SMD, you already touched earlier that there's in the previous podcast we discussed the trailblazing GPs who've been working in that field already. That's newly qualified GPs who do projects around health inequalities. And I think there's an awful lot more that we can do around that as part of this much broader research community of practice within NCGPA and partners beyond, like public health and the Mental Health Trust, to actually make sure that that good research and good practice is at the heart of everything that we do, in the same way that the voice of lived experience is. And indeed, already in the Opportunity Nottingham programme that was in existence before, and in the Changing Futures programme, there are peer researchers. So the voice of lived experience is very much involved in research projects that are undertaken, and I think it would be good to emulate that way of working and embed that.
No, absolutely. It's an area of NCGPA work I'm quite excited to see how it develops, actually, because I think there is a lot of appetite within general practice for people to do research. I think it's something people would like to do, but it's just not something we traditionally I've done in our day-to-day jobs. I'm really interested, but both personally and for my colleagues, to see how that aspect develops. So Jane, we're looking at a diagram with those 4 areas that we've just discussed: online presence, workforce development, lived experience and research around the edge. And then there's a bigger circle in the middle. And I guess part of that is being a sum of its parts, the areas that we've discussed. But what else is going to be there, or do you think sort of needs to be there to tie it all together and make it effective? What's in the middle?
Well, one of the things I've been looking at is how the system works currently with other groups of patients who require or for whom it's helpful to have a system of better communication and sharing of best practice across the city or across other areas. And I've been looking at how the safeguarding networks and groups work, because there is actually quite a lot of overlap between child safeguarding, adult safeguarding, and SMD. Particularly as we talked on in the last podcast, we mentioned that those suffering severe and multiple disadvantage, about 85 to 90% have experienced adverse childhood events. So looking at how that works, and this is at a very early stage, and if there are any examples of this out there in the world where somebody's ahead of the game on this, I'd be really interested to know. And also if people have any thoughts and feelings about how a safeguarding type network could work for health inequalities, I'd be very, very grateful to hear from them. But my thoughts are that there are various levels at which it could work, which is at the ICB level. There would be a strategic input allied really to as part of the health inequalities programme. At place-based partnership, you would have a sort of, in a way, somewhere between a strategic and implementation role, very similar to the one that, well, probably your role, Andy. And then within primary care networks, you would have a worker, part of the network, possibly even, and I know this has already been explored in other PCNs that are more sort of individual rather than as part of a large city, to actually have a social prescriber who has a specific role in this, or is a sort of lead, SMD lead within a social prescribing team, or indeed it could be a practice nurse somewhere in the PCN who has a particular interest in this field, who can coordinate across the PCN and coordinate training and information sharing and support. And then within every practice there would be, as there already is, if you signed up to the local enhanced service, you would have an SMD lead. I can see that in order not to sort of bombard people with lots of extra roles, this would actually fit almost very neatly with the safeguarding and both child and adult safeguarding team. At Platform One, we ran the team as well, it wasn't an individual person, we ran it as a group with an administrator, a nurse and a GP having roles within that, who worked together on it. And I think that I felt that worked particularly well. I don't know how you think that would go, Andy, in other practices, but I think then it means that you're not having GPs doing administrative work in a role which they're far too expensive to be doing. And equally, you've got a nurse who probably, particularly with children or with families, has a much closer engagement through child health clinics, etc., than maybe a GP would. But the whole thing can come together with allied health professionals like health visitors and midwives or whatever, and to work together. A similar type of arrangement, I think, whether it's tacked onto that or whether it's a separate one. I've got quite a few meetings booked over the next few months with PCM representatives with deep end practices and things to really tease out how people feel that they could best implement this without, so that there are benefits to the way in which they work without massive additional burdens, which obviously would be completely untenable at the moment.
I think you're right, Jane. It's getting that balance, isn't it, between getting the profile for something which is new or requires attention, and often the solution from the system is we'll create a lead for that, and you can end up as a practice, just speaking from our practice perspective, you can have a lead for all sorts of things. You've got the dementia lead, inequalities lead, SMD lead, access champion, digital lead. The list goes on, and it can become a bit confusing. So I think there's balancing that aspect with actually just helping people who already do a job which encompasses many aspects of what you want to improve, and actually doing something to help them do their job better, which I think where some of the training or support offers, or targeting new roles to support these aspects of existing activity, is really good. So it's quite refreshing to sort of hear that and know that that's being considered as we design our interventions. The other thing which I'm hearing a lot of other organisations beginning to be mentioned now. So we've got primary care network staff and AORS staff. You mentioned place as well. You also mentioned the deep end surgeries. The deep end group in Nottingham, actually, and maybe we can provide a link to their Twitter, Maisie, in the show notes, is becoming really quite active. And I've been part of that since the beginning. So very grateful that you'll be coming on to talk to us soon, Jane, to link in this work with that group of practice which represents the bottom decile, so the bottom 10% of practice. Let me get this right. So they represent practices who give care to people in the bottom 10% of inequality. So the 10% most deprived populations in Nottingham. I think I've not quite represented that right. But anyway, so lots of different organisations, different agendas, and I guess part of this is trying to kind of pull together and coordinate that activity. Do you have any thoughts on how to do that effectively?
Well, I think there was a lot of learning gained during COVID, when all the different organisations came together with everybody in. And I think we learned an awful lot from that about where there are barriers to working together, how we can overcome them. And generally, it's just by actually talking and sharing what the problems are, and just looking at what practically can be done quite quickly without, without the need for involving all sorts of hierarchy and things, because very often people at the coalface in sort of frontline situations can, just by communication between different areas, can really facilitate a lot of partnership working, and that then gets, as that gets fed back up the system, and more at place level, the whole group can start working together in a much more communicative and supportive way. And I think that absolutely happened, and we've managed to build on that. Well, the person leading that and driving it particularly was Jane Turrill, who was then working in public health at the City Council. She's now working in public health with the Mental Health Trust, but continues to drive and support that, as do those within the Changing Futures programme, which, as I say, sort of came out of that. The bid came out of that group. So I think we've learned an awful lot from how a partnership way of working is helpful. I think the next stage, if you like, is introducing those benefits, and indeed introducing those partners within practice to practices on the ground. So at the sort of higher levels of commissioning and decision making processes, people are often very used to working, and they know all the different actors in the on the stage, as it were. But I think at practice level there is less understanding of how all the different bits fit together. And I think with the online work that we're doing from the embedded work is actually in all of those organisations. Part of their role is to actually bridge those gaps or bring those services together and improve communication between them, so that there is less chance of people falling between the cracks. I mean, I always used to sort of think of, when I first started working at Platform One, that the system was very much like a glass of lemonade with lots and lots of little bubbles of services in it, and most people actually sort of swimming around in the bits between. And actually what we need to do is actually make pathways between those bubbles and link them all up, so that actually the transition between high-end SMD services, as we were saying earlier, and maybe social prescribers is linked easily going upwards, but also is the sort of traffic both ways is accepted with trusted assessments and a way of working between parts of the system that enables this to happen. Difficult to build, but it's an aspiration I have.
Yeah, absolutely. Yeah, I think what I'm hearing is it's about getting the communication right between the different stakeholders, the different parts of the system that need to work together. And I guess part of that is getting the individual people who have an interest in this area connected with one another and knowing each other, and and actually genuinely networking and just working together. I'm often a fan of, I know this is going to be the Centre of Excellence for SMD, in primary care. I'm also a fan of the network model as well, where you say actually this is a network, an SMD network in Nottingham. I think that often emphasises better the role that individuals play. A centre for excellence can sometimes feel a bit like it's something that's not you, that's a bit of an ivory tower. Maybe it's a little bit academic and it's central. It's away. And so I quite like the network concept and way of articulating it. I think that's what you're describing anyway. But just interesting thoughts.
Yes. The name can be varied with very early stages. So, I think that's interesting. But I think also the only thing I think it's actually quite valuable to start thinking about excellence in this field is something I know we've talked about before, is that in other areas of medicine, for instance, if we're looking at cardiothoracic surgery, a cardiothoracic surgeon who deals with the most complex and difficult hearts is seen as at the head of his profession and as an aspirational role for young cardiothoracic surgeons joining the profession, that branch of the profession. I think in general practice, for many years we've had a very much a focus on excellence in general practice as being seen as a well-run, well-organized practice, and I think there is something about, and I think some of this needs to go back into looking at medical education as well, which I know is a huge topic, which I won't go into too much at this moment, but looking at the general practice where you are looking after the most complex patients as being the most aspirational. I don't know.
It's really it's really interesting. I mean, I work in a fairly deprived area, so it's really nice to hear that. I guess what we're talking about is how we frame success in general practice, and I guess traditionally we might have defined success as having patients who have the best outcomes, live the longest lives, manage their diseases the best themselves, have the best sort of business outcomes in terms of attainment and so forth. But that sort of ignores that not all practices are starting from the same place. Not all patients are as able to give equal attention to their medical conditions, and some people have complex lives and other things going on that means that they don't achieve as good health outcomes. And it's not to do with the quality of the care they're receiving. Often that's the same, or it's better, or it's maybe not quite as good, but not so bad as should produce more negative outcomes for their patients. And I guess what you say is maybe we need to reframe that and think, actually, is there another way to look at it, and is there another way to improve the status of those practices who do a really, really good job but work in quite difficult areas with populations with lots of challenges? I think that's what I've heard you say, and I think that's a really good question. It's a difficult one to answer, isn't it? I don't know what measures you would use, and but maybe it's possible to design those.
I think it's interesting, but the Health Select Committee's new report has identified that there is probably a need to recognise that delivering really good health outcomes for different groups of people doesn't necessarily cost the same, and those investment in delivering the service to people with particular disadvantages and experiencing health inequalities is a way forward, potentially. I know we've been there before. That was the ethos that the Platform One's commissioning. And then the spirit changed, and it was all about equality of payment for every single patient should get the same. But I think, frankly, that doesn't acknowledge the fact that to deliver not extra care or special care, but the kind of normal primary care that everybody takes for granted to people who are experiencing disadvantage and health inequalities actually costs more. And there is starting to again be an acknowledgement of that. Obviously, the SMD LES is a payment to facilitate a flexible approach, not to deliver better care than anybody else, but to allow people equality of access to good primary care. If that makes sense.
I agree. It's really nice to see these concepts coming through in things like the Health Select Committee report. They're talking about looking at the Cahill formula again, which doesn't adequately or even doesn't at all, wait for deprivation. And actually even looking at things like looking at QOF and IIF and possibly even abolishing that and recycling that money in new ways to support the development of healthcare that we want. So maybe things will swing back in the direction of supporting equity and SMD again for the next few years, hopefully. So I guess that's a bit of a hopeful note to bring us towards the end of the discussion, really, that maybe things could change. I am very excited to see how the Centre for Excellence in SMD develops within Nottingham City. I think it's a really, really exciting concept in a way that Nottingham could lead the country in dealing with SMD. I'm sure there's lots of good work going on in other places as well. Any final words, Jane? What we often ask at the end is, what should people do next, having listened to this conversation? They should listen to the last one, so that's the first thing they should do if they've not done it already. But after that, what would you like people to do next?
I think I would like, actually, people locally or indeed anywhere who are working this field and have got ideas about this to share them with me. You can put a link here via NCGPA comms to be forwarded to me. That would be great, because I think one of the things I've been so much aware of is you can find people all over the place inventing the same wheel. And I think it's really, I've already put out feelers through the Changing Futures National Network to see what's happening in other areas. It's really different in different parts of the country. It's quite fascinating, but I think as well that I want to build on that recognition that sort of health inequalities and SMD are not different things. That one is a consequence, if you like, of part of the other. But certainly I'm very happy to discuss my work with anybody who's working in that field, or indeed I am, as I say already, trying to reach out to a lot of different groups within Nottingham and Nottinghamshire to glean as much information about how this should go forward. And in a way, it's not just about patients' lived experience, it's actually about the lived experience of staff, to inform how best we can support going forward to have a much more equitable service. And it is a service. We are a service industry for people across the county and the city.
Absolutely. So, and I think we've got some information. So if people want to reach out and share their experiences with Jane, then Jane can be contacted through info@ncgpa.org.uk. And so I think that's a really nice place to end. And thanks very much for your time today, Jane. It's been really, really interesting. Enjoyed our chats both on camera and off camera as we've produced these 2 episodes for people. And thank you very much, and goodbye, and see you later.
Thank you very much indeed. Thank you.